Hello, my name is Todd Schoenbaum, and our program for today is immediate implant provisionals in the aesthetic zone. The use of immediate implant provisionals in the aesthetic zone will be dividing into 3 stages. The use of this provisional is designed for times when we cannot or desire not to place the definitive abutment on the implant at the time of surgery, but would like to restore the teeth and help support the gingival architecture at the time the implant is placed. I like to think of provisionals on implants when they're placed immediately on the day of surgery as having 3 distinct stages. At each stage, the provisional restoration will serve a distinct function, have distinct responsibilities, and have distinct outcome goals. In the initial stage of the implant provisional restoration, our primary goal is to protect the surgical site. In protecting the surgical site, we'll help to maximize the gingival volume around the implant provisional. After 3 to 6 months, we'll move into stage 2, where we will begin to shape the gingival tissue. In this stage, we want to help encourage the proper architecture of the soft tissue around the implant without unduly traumatizing the peri-implant tissue with constant removal and reattachment. In the third and final stage, we will be attempting to capture the exact position of the soft tissue architecture in such a manner as to exactly replicate on the laboratory casts the position we have in the clinical setting. Stage 1 of the immediate implant provisional restoration of the screw retain type. As I mentioned, our primary goal here is to protect the surgical site. I like to inform the patient that with this provisional restoration, we will be able to provide them with a reasonable aesthetic outcome, but in the initial stages, we may have some compromises with the embrasures or with the length of the tooth form. Prior to starting the surgery, our laboratory technician partner will be asked to fabricate 3 materials prior to the surgery. The first of which is an acrylic provisional shell. In this image on the left, you can see that there's already a hole drilled in the shell, and at this point, we actually prefer it not to be done that way. We don't know exactly where the implant is going to be placed when we're not using a computer-guided surgery, and so the actual position of the hole will be determined at the time of delivery of the provisional restoration. It's nice to have an acrylic shell prefabricated because primarily it will enhance the aesthetic outcome of the case. Additionally, it helps the technician get involved in the case at an early stage so that we can work out any aesthetic issues from day 1. Additionally, we'll be fabricating a delivery matrix. This is primarily fabricated out of a putty-type material off of the wax-up, which will allow us to properly insert the provisional shell into its position in the mouth when we fabricate the provisional restoration. The third and final component of this will be a titanium provisional abutment, not to be mistaken with the plastic abutments commonly available. With some implant companies, the only provisional abutments they have available are a PEEK fused to titanium abutment, and while it's advantageous to have the titanium component at the head of the implant, we have seen problems with fracture of the PEEK component. In such situations, we prefer to actually select a definitive titanium abutment even for use in the provisional stage. You can see in this image that we've made a few modifications to the provisional abutment. Many of these titanium provisional abutments come designed with a flare at the apical extent of the abutment. The problem with this is that on the day of surgery, when we are going to be fabricating the provisional restoration, this flare has a tendency to cause a few problems. The most important of which is that it tends to place undue pressure on the peri-implant surgical site. The flared area you can see around this provisional abutment will artificially displace the gingival tissue. It is also prone to catching on the sutures of the peri-implant area with that square shoulder. Fortunately, this shoulder and the flare are not structurally necessary for the integrity of the provisional restoration. To date, we have yet to have any problems with fracture of these abutments even after the modification, which I'll propose in just a moment. Additionally, we don't want this change in contour that we see with the flare at that apical extent where it meets the implant. Where the provisional abutment meets the implant, we are going to have the meeting of 4 distinct tissue types, if you might say, in that one area. Typically, we're going to have the bone, the soft tissue, the head of the implant, and the junction of the abutment all coinciding at that one point. The last thing we want at that junction is a change in contour, which will lead to bacterial accumulation, possible inflammation, and possible bone recession and gingival recession. So our modification of this abutment is fairly straightforward. we take these abutments and attach them to a protection analog and simply remove the flared portion of that. Our ideal design when doing this is to create a straight profile off the head of the abutment. For some platform switch design implants like the Noble Active, we have already accomplished this in the provisional abutment stage without having to modify it. In this diagram, you'll see a step-by-step image series of how to accomplish this procedure. Starting with the image on the left, we have the provisional abutment attached to a protection analog. We then use a heatless stone in the laboratory to modify the flare and to trim it off, as you'll see in the third image. After cutting off the flare of the abutment, we need to polish that down with titanium polishing instruments in the laboratory. Either chairside clinician or the laboratory technician can accomplish this in a fairly straightforward manner. For adhesive reasons, we like to sandblast the retentive surface of the abutment. The resin components and the acrylic components don't inherently bond to the titanium, so by sandblasting it, we're able to increase the retention and minimize the possibility of fracture of the provisional restoration. However, we have just spent the time adjusting and polishing the subgingival emergence of the abutment, and we want to protect that with sticky wax before the air abrasion process. After air abrasion, we like to coat it with an opaquing medium. Since we are speaking about provisionals in the aesthetic zone, we obviously don't want to have the gray metal show through of the provisional restoration and want to keep the value and the chroma of the restoration as accurate as possible. In doing so, we like to paint that roughened titanium surface with a light-cured opaquing resin, as you'll see on the far right. This is a product similar to we might use for composite veneers for opaquing out a dark tooth preparation, for example. It's a light-cured resin component, and it will enable the restoration to be ready for the luting to the provisional shell in the next step. Again, these steps are typically done prior to the day of surgery and prior to the day of fabrication of the provisional. After surgery, the patient will typically come to my office within an hour or two of the surgical procedure, typically with the healing abutment in place and oftentimes peri-implant graft materials and a few sutures. As you can see here, we're going to use the putty matrix to properly index the alignment of that implant. When properly designed, the putty matrix will have two windows at either side on the adjacent natural dentition so that we can ensure that the matrix is fully seated. The hole over the implant is created such that we have full palatal access and up to the incisal edge. The use of this will become apparent in just a moment. In the mouth, we like to visualize the line of draw coming off the implant and mark that with a crosshair diagram, as you can see on the right, with an indelible marker. That will enable us, when we go to modify the provisional shell, to create the hole in the most accurate position through that shell. After the surgery, the patient will come to me. I will remove the healing abutment, attach the titanium provisional abutment, as you can see in this diagram. The titanium abutment will need to be modified typically. When properly designed, the titanium abutment will have too much length to allow us to seat the provisional shell over the top of it. As such, we will need to trim it down. I prefer not to do this in the mouth and prefer to actually mark the estimated length of that provisional abutment, as you can see here again with a marker, and remove it from the mouth for trimming. As we have a fresh surgical site, the last thing I want to do is to deliver a series of titanium shards and debris into the surgical site immediately following the procedure. So we mark that with a marker, remove it from the mouth, and make the adjustments extraorally. After doing so, the abutment is placed back in the mouth in its shorter length, and it's confirmed that the provisional shell will fit over the top of that. We then use the putty matrix to deliver the provisional shell to the predetermined position based on the wax-up. As you can see here, we're going to use a narrow tip with flowable composite. Alternatively, auto-curing acrylic resin could also be used. I like to use the flowable composite because it allows us to have a light cure component where we can set the cure at our desired time. It is important not to inject the material down the screw access hole, obviously, and the composite material is injected between the abutment and the interior of the shell. Sometimes I have found it useful when we have excessive space in the area to initially line the interior of the acrylic shell with the composite resin and initially line the outside of the provisional abutment with that composite resin as well, helping to create a linkage between them. Once we can visualize that we have sufficient composite resin in between the shell and the abutment, it is now time to cure it and remove it. Upon removing the putty matrix and subsequently removing the initial portion of the provisional restoration, you can see that it's typically not very biologically compatible. It's typically quite rough, oftentimes bloody from the surgery, and needs to be appropriately cleaned. We like to use a steam cleaner to clean off the debris and the blood from the provisional restoration before proceeding, followed by a light sandblasting, cleaning, application of adhesive resin, and then shaping with a composite resin. With that, I would like to thank you for taking your time with me. I look forward to seeing you again, either here at the gIDE facility in Los Angeles or on another video. Thank you.
For more education programs, visit the gIDE Institute at www.guidedental.com.